Welcome to a new case presentation from the ASAS case library. My name is Dr. Denis, and together with Dr. Kai, we will navigate you through a brand new case of the library. So if you go to the ASAS case library, you will find a new case, case number 43. And this is nowadays rather rare case, but still quite important because at this disease stage, we might encounter some disease complications, which are almost not present at an early disease. So in this case, we're talking about 70-year-old male patient with known diagnosis of axial spondyloarthritis, radiographic form for about 40 years. At present, he has no relevant back pain, but substantial limitation of spinal mobility and kyphotic posture, making his daily life quite problematic. He has a history of chronic back pain with inflammatory characteristic over many years, with typical nocturnal pain, with early morning awakening, prolonged morning stiffness. He has been treated so far only with NSAIDs, which he took on demand. There are not that many other spondyloarthritis manifestations, except several episodes of acute anterior uveitis many years ago. There is a case of axial spondyloarthritis in the family. His father is suffering from axSpA, and from social history, we know that he is a former construction worker, and currently there is a problem with regular exercises because of the already mentioned spinal mobility limitations. At physical examination, there was no pressure tenderness over sacroiliac joints, no peripheral arthritis, no enthesitis, but you see that spinal mobility was substantially limited, with nearly all tests being in a very restrictive area with Schober of only 0.5 and cervical rotation barely reaching 20 degrees. The lab was largely unremarkable, with HLA-B27 being positive and CRP being within the normal range. We have several imaging modalities from this patient. We will start with X-rays. So here you see an X-ray of lumbar spine with sacroiliac joints, and what you see already that the diagnosis was most likely correct. We see a spine resembling a bamboo stab with complete ankylosis of sacroiliac joints. On the lateral view of this lumbar spine, we see that indeed there is quite extensive new bone formation resulting into complete ankylosis of the spine. You don't see really any open segment with syndesmophytes going from thoracic spine through lumbar spine till this process of ossification reaches sacrum. Same continues if we go up to the thoracic spine. You see classical syndesmophytes reaching all the vertebral bodies in the thoracic spine. The same on lateral view, and pretty similar picture you can see also in the cervical spine, with syndesmophytes going from top to down. So in such a case, there are several questions we need to discuss also with a radiologist. So one aspect is definitely the diagnosis. I think diagnosis is pretty correct in this situation. And the next question is, do we have any inflammatory activity, we need to improve better. So we don't have that many indicators of uncontrolled inflammatory activity, because back pain seems to be quite okay right now, and there are no systemic marker of inflammatory activity, but still we want to know if there is inflammatory activity, and then we definitely want to see how those advanced structural changes appear on cross-sectional imaging. Kai, would you like to guide us through MRIs and CT from this case?
Yes, I very much like to do it. So here we see the MRI scan of this patient. We're starting with a T1-weighted scan of the sacroiliac joint in oblique coronal slice orientation. And as expected, there's full ankylosis here in the joints. If you are not familiar with MRI, you might think that there is the joint still here, but compared to a normal joint, this gap between the sacral bone and the iliac bone is much too narrow. And so this is like the remnant of the cortex of the two bones that is persistent here. And that will maybe also be persistent for the next 20 years, because it's very slow that this is getting taken over by osteoclasts and will slowly disappear. Also here on the left side, we can see this line, which is called in some publications a phantom line. And in other cases, you would even see the fatty marrow in the joint space growing in like an extended version of backfill. But here it's already so advanced that this is now fully fused. We will see soon also the images of the spine, but unfortunately we don't have a CT of this of the pelvis here. Regarding active inflammation, of course, it's mandatory to look at a T2 weighted sequence with fat saturation, which is in most of the times a stir sequence. And here we can see that the stir sequence is well executed, is capturing the entire joint, and we can see that there is no inflammatory activity whatsoever. So here we can assume the former joint space. There's no edema surrounding this area. There is some bright stripes over here, which if you compare it actually with the T1, then you see that this is outside of the joint. So this is the cortex of the ilium, and here we have the so-called retroarticular space. And if we compare the left, so the anatomic position is a bit different. So here we see it on the right joint, and to see it on the left joint, we need to go here to slice 12, where we can see that the fibers of the interosseous ligaments, they are well preserved, but they are expressing some high signal, which is relatable to enthesitis of the interosseous ligaments. Also, we as radiologists, we tend to look at the entire image. So we see that in this elderly patient, there is already some irregular contour of the urine bladder, which is maybe due to prostatic complications. And we also see some diverticulum here at the urine bladder. But this is the side findings for our purposes. Looking at the MRI of the spine, we have this nice set of total spine imaging. So we can see the entire spine from the C1 till the L5, and we can even appreciate the sacrum. And this technique is only possible if you have a modern MRI scanner that is capable of stitching. So we have one acquisition of the upper part and one acquisition of the lower part, and there's a workstation connected to this MRI machine that fuses both images and does a perfect overlap between the two. So you can hardly see any signal void here in between. So this is a very good example. Sometimes there are artifacts at this area, where there are some stitching artifacts, low signal intensity. In some instances, 3 sections need to be acquired, like the cervical spine, mid-thoracic spine, and lumbar spine. So you have 2 areas with signal voids. But this is all not the case here. And if you look at the intervertebral levels, you can distinguish those in the lower thoracic spine that show the nucleus pulposus in a low signal intensity appearance, which is normal. And then you see the lumbar discs, which have a high signal intensity on a T1 weighted scan. And this is your sign that here is ankylosis apparent in these intervertebral discs, not only in the anterior fibers of the annulus fibrosus, as we have seen it from the X-ray. So we know there is some ossification here in the annulus fibrosus. But do we know if there is ossification also here in between? Image quality is somewhat limited here in this area. And with CT, we would see more. But we can see based on this MRI scan that there is some ossification also through the disc. So there are 2 different patterns of ossifications. And also, if you look at the cervical spine, we can appreciate the same. We see that there is some high signal over here in the first couple of discs, and later down here it's all dark. And if we compare it, here we also have the ankylosis in the annulus fibrosus fibers, but also throughout the disc. And this can be checked with the CT scan that we have in this patient. So this is a thoracic CT scan that was done to evaluate his lungs. But of course, we can nicely reformat the bones and can look here. And you see there is still some cortex here, and there's some dark appearance here. So the ossification is slowly growing. If you for instance focus on that segment, you see there is some full ankylosis in the posterior, like 1/3, and there's some residual disc over here. And on the MRI, you see that there is fat content mainly in these areas. Touching on the inflammatory part of the disease, of course, we need to check the stir sequence of the spine. And here, all the vertebral bodies, they look normal. There's no bone marrow edema in the vertebral bodies. So this rules out any corner-related inflammatory lesions or anterior spondylitis. But it is also important to look at the lateral slices, where we would see the facet joints here at the entire spine, or the costovertebral joints that are sometimes visualized very good at the thoracic spine. But here in this patient, all these joints are negative, don't show any active inflammation. So this is a non-active patient with radiographic axial spondyloarthritis. We have nicely compiled this information also here as a text, so you can read it if you don't have the time to follow this video. And Denis, I give it back to you. Are there any points that we should touch on?
Thank you very much, Kai, for the explanation of cross-sectional imaging. I think this is a very good and nice example, a reference case for advanced disease in axial SPA. We don't see that complete ankylosis very often nowadays. And this is probably related to the fact that the treatment of axial spondyloarthritis changed dramatically. So people coming nowadays to us, they would never, in most of the cases, would never achieve this disease stage because of improved control of inflammatory activity. So occasionally we see those cases coming to us with some late problems. And one of the problems that was obvious in this case was an unfavorable posture related to hyperkyphosis and severe ankylosis. If it is clinically relevant for quality of life in a patient, then there is an option for corrective osteotomy for surgical intervention, correcting this severe hyperkyphosis. Ideally, this procedure should be done in a reference center. There are not that many overall in the world because the number of those procedures declined substantially in the last years. And another important thing why imaging may be necessary in such a case, aside of the question of inflammatory activity, is a question of potential mechanical instability and fracture of this completely ankylosed, very stiff but also very fragile spine. We haven't seen any signs of mechanical instability, don't we, Kai?
No, we didn't see such thing in this patient, but it's very important, as you said, to search for late complication of the disease, and there basically are two of them that we know. One you mentioned already, that is the fracture of the bamboo spine, which is can be life-threatening as there's damage to the spinal cord that can happen. So this needs to be detected. I will soon show some hints on how to search for it on MRI. And the other, even rarer complication is the cauda equina syndrome, where we have, due to the chronic inflammation going on next to the fibers of the cauda equina, they can be glued together by these inflammatory cells and scar tissue, and are glued to the sides of the vertebral canal, of the spinal canal, and that leads to like valve mechanism extending the spinal canal, and this can lead also to spinal problems. If we go to the case again and search for a fracture, my recommendation is to use a T1 weighted scan and to have a look at each of these vertebral levels if there are dark sclerotic lines. So in a ankylosis, maybe we present such a case in a future case recording. We have dark sclerotic lines, and these lines, they extend to the posterior aspect of the vertebral spine. So that would show us that there is some mechanical instability. And of course, in severe cases, they then also show some edema here in the spine, but also in the posterior elements. So that is the learning from this case. I hope you had some learning moments here from our presentation, and as a thing to remember, this ASAS online case library is something for all of us. So if you have a case to present, you can approach Denis and me on the social channels or via the ASAS email. There's some hints on how to submit the cases, and maybe your case is the next one that we will showcase here and even invite you to present.
Thank you very much for watching and listening. Stay tuned. We will present a new case very soon.
Bye-bye.